Good evening, everyone. This is our 36th webinar. The endeavor which started in the COVID times and it is going strong day by day. And it's our privilege to be, organizing these focused webinars on different aspects of breast cancer. So for the welcome address, I would like to invite Dr. Rajiv Agarwal. Dr. Rajiv.
Yeah,
Good
evening. As Dr. Vaishali said, this is our 36th seminar in the last 4.5 years. We are taking one particular topic and trying to discuss. This time we have taken a topic of breast imaging because for every breast problem, the management starts from the diagnosis, and breast imaging plays a very, very important role. Today, I am very happy to mention that we have a galaxy of faculty, like a organ-based clinicians. They are the organ-based radiologists who have dedicated their decades of experience in the isolated breast imaging, and we are happy to have all of them dedicated breast radiologists. So, without wasting much time, I once again welcome to all the delegates, my faculty, and of course, thanks to the MICE ideas, over to Vaishali.
Thank you, sir. So I am going to be your navigator for today's webinar. It is my proud privilege to be inviting Dr. Jyoti Arora. Dr. Jyoti is one of the best names in breast imaging in our country. I can go to the extent of saying that she is a dream team member for all the breast surgeons of our country and an imaging expert par excellence. So, to accommodate her tight academic schedule, we have actually modified our flow of the webinar so that we don't miss out on the great learning which she's going to share with us. So, Dr. Jyoti, welcome and over to you.
Thank you, Dr. Vaishali, for such kind introduction, and thank you for accommodating my last minute request. Had a
It's our
meeting at
privilege.
7, so that's why I could not take the session at that time. So really thank you for taking the challenging cases, which are generally at the end of any session, for accommodating me at the start of the session. So with this, I would like to share my talk. Right. Okay, so I'll be going on interesting cases. I'll be showing three interesting cases and how we reached that diagnosis and what were the learning points or the key takeaways from those cases. Okay. So the first case was a premenopausal female with left breast lump. She was already diagnosed outside and she came to us for a second opinion. So the left, she already had a biopsy proven radial scar on the right side. So that was not of our concern. And it was planned that whenever the surgery goes ahead, that will get removed. But on the left side, which was the symptomatic side, I could see focal asymmetry in the upper outer quadrant of the left breast. Um, this was all the external images that were done outside. This was the ultrasound, which showed a very, very hyperechoic mass that you can see here. This was, as you all know, hyperechogenicity. Most of the times, it's more of a sign of benignity rather than malignancy. But as they say, with any palpable lump, it's always better to do a triple assessment. She also had an MR. This MR did show an isoglandular mass here, which was slightly hyperintense on T2. And the enhancement was very minimal on the early phase, but on the later phases, rather than the washout that we see in the late phases, this was showing progressive enhancement. And the true cut biopsy that she had from outside said that sections and the deeper sections show fibromuscular tissue and few variable size dilated vessel, no evidence of glandular tissue. Now, no evidence of glandular tissue, and also there were no malignant cells, was something that intrigued me because this kind of an appearance could fit into a hematoma with a lot of fat tissue. That's why it was very hyperechoic. But then not getting any fibroglandular tissue, for me, this was a rat path discordance. So because this repeat biopsy was advised for her, but patient came after few months as it was the COVID time, and there was also increase in the size when she came to us again. So now you can see there's a definite, which was seen as focal asymmetry. Now you can see it as a mass now. And on the ultrasound, something which was completely hyperechoic. Now between the hyperechogenicity, there were low echogenic areas as well. And the MR now showed much more enhancements as compared to what we saw last time. And there were acute and areas of subacute or chronic blood within this mass. So this time we did the biopsy, the repeat biopsy, because we didn't want, it was a palpable, so there was no chance of getting the target missed. But because the two things were not fitting, we decided to do VAP from both the hyper as well as the hypoechoic areas. And this came back as primary angiosarcoma. So we always have, like, it's an angio thing. We think VAP may not be able to give us the diagnosis, but what happens is because of the blood pools, at times the cells, they get dispersed and you might hit an area which might be just blood rather than the tumor cells might be there. So we have to be very, very particular about establishing a rat path concordance. If there is a discordance, then something needs to be done further, which could be either a follow-up or a repeat biopsy or an excision biopsy. So this I wanted to show. When the PET was done, you can see there were very few areas that were showing FDG avidity, which was also not very high. And but a lot of areas which were not FDG avid, which were probably the blood pool areas. Unfortunately, this patient came back to, she had a treatment, she had a left side mastectomy, radial scar was also removed, but there was another mass that was seen that developed after 2 years. So you can see here, there was a mass, nothing was there on the prior. This now looked like a typical malignant mass. We did the biopsy again. It was a primary angiosarcoma for this lady. You can see again that the uptake was not very high. It was there, but not very high, again, likely because it's mixed with blood pools. So establishing rat-path concordance and keeping your suspicion, the threshold for doing a repeat biopsy, depending on what the findings are, is important. Now, this lady, a postmenopausal female, came to us for lumpiness in the upper outer quadrant in the left breast. Now, she was again came for a second opinion. She had her battery of test in January 2019, and the radiologist told her to come for a follow up and to come to us for the follow up because he felt something was not right. So, here I saw the distortion, there was skin retraction. So I told her, it looks worrying. I need to do further testing. And the lady who had come to me from Gujarat, she said, "Ma'am, this everybody gets worried about it. I had a benign lumpectomy in 2011, and this was there on my previous mammograms also." So I asked her to show me. So this was the one in Jan, after which the radiologist there had asked her to come to us for second opinion. And there was this distortion even then, and there was distortion even in 2018, and this was right in the area of her previous lumpectomy. She also had an FNAC, which was blind, the palpable lump, or the area of lumpiness, which was negative. She also had an MR done, which she said was negative, which I'm just going to show you. But then, to me, such a lot of scarrings, like it's a completely distorted area, should not happen with a benign lumpectomy. With benign lumpectomy, especially after 8 years, hardly a scar is seen. And even if it is there, it's very subtle. It can't be that prominent. So I asked her, does she have any other previous mammogram? And she showed me another one from 2014, which was also after the surgery. And here you can see there is no scarring in the upper outer quadrant. So with benign lumpectomies, a delayed scarring is very, very less likely. And as you see, this is actually increasing. This was our center. So these are because of the exposure factors, they look very dense. It wasn't that dense. That's why it was being called as benign scarring. But there's definitely a lot more skin retraction that you can see. And this was her MR, and why it was called negative, because in the early phase, you can see there is hardly any enhancement on the very, very delayed images. There is just a little bit of enhancement that anybody can overlook it, saying as a background or post-operative slight enhancement. So these are the MIP images, the very first image that you can, the very first early post contrast is hardly showing any enhancement. So now, with all this, the fact that she has a lump, which was the lumpiness was increasing, and also it had come after this, after a few years of the surgery, made me very, very suspicious. So I went ahead with an ultrasound, and did all my used all my tools in the ultrasound armamentarium, elastography, and then harmonics, a lot of compression, and then I could see this little area of shadowing. It is becoming very obvious now because the way I've taken the picture, but it was just showing dirty shadowing on the ultrasound, and I could give importance to this shadowing that I was seeing because I had a reason now, because the history was such, and the comparison with the previous made me very, very suspicious. This was the lymph node, although it was a smooth thickening, but definitely more than 3 millimeters. So biopsy was done, and it came out as invasive lobulars. Invasive lobulars can really um, create a lot of diagnostic dilemma, and we again need to have a very high level of suspicion when dealing with such cases. So establishing clinical rat path concordance is a must. Procedures should always be done image guided. FNACs is an obsolete test, so they should not be done. It just gave the patient, the radiologist had, I think, fair bit of a suspicion, But because FNAC was negative, so he thought that, it can be followed it up. So it's an obsolete test. It should not be done for breast masses. And comparison with previous mammogram, not just one previous, but at times we have to compare with 3-4 years back mammograms, because that help us to see subtle changes. So that is must. And take a detailed history that can really solve your mystery. So last, this was a very interesting one, so I have added this one also. This was a screen detected cancer, 45-year-old. She was 45 at that time in 2018. She had surgery, chemo, radio, everything got over in 2019. So this was her first post radiotherapy mammogram. You can see skin thickening and as well as edema, which is expected in post radiotherapy first mammograms. In 2023, all that thickening had settled and the edema has settled, but there is this obvious case of fat necrosis. We can see the fat really well, and there is coarse microcalcification, very typical of fat necrosis. Now, she came back to us in 24 and presented with a history of trauma. So there was marked skin thickening and blackish discoloration that she was having. So because there was so much of skin thickening and edema, the clinician decided to call her back in 6 weeks and then get all her investigations done. So she came back in 6 weeks time, and the skin thickening hadn't settled, and along with the bluish along the right lateral chest wall, there is some now new bluish discoloration also. So we did the mammogram, and you can see the skin thickening has definitely now has increased as compared to her last mammogram, and there was a lot of edema. I could also see a new lump here, which on ultrasound looked like a hematoma rather than anything to worry about. There wasn't any vascularity, but edema and skin thickening really limited the diagnostic capability of the ultrasound. So the visibility was very poor. Um, these are the ultrasound images. A lot of edema, a lot of skin thickening. This was in the area of that bluish discoloration. This is fat necrosis. You can see coarse calcifications, a lot of posterior shadowing because of calcifications. This was the hematoma. No, there was no vascularity in it. And again, lot of edema that you can see here. So we did an MR because we were not knowing what exactly is happening. If it was really trauma, it should have settled things at least to some bit in the 6 weeks time. You can see again mark thickening, mark edema that's present in the post-treated breast. On the contrast images, this was the hematoma, this was the fat necrosis. So in the outer half, there was no significant enhancement, only some enhancement in the retroareolar region and some mild generalized diffuse uptake, which was obviously more in the retroareolar region. Now, because things were not matching, the history and the clinical findings, there was very marked skin thickening and discoloration. And on MR and on ultrasound, we could not really find a mass, an enhancing mass that we could indicate that this is the culprit. We decided to go for a punch biopsy with a mind that if that reveals the some abnormality, it's fine. Otherwise, we'll go for an MR guided. So the punch biopsy revealed post radiation secondary angiosarcoma. So in all the three cases, they were not straightforward cases, but establishing the clinico-rad path concordance is a must. And whenever we go in a stepwise manner, do our triple assessment, and if all the three things are not aligned, that's the time when we need to think out of the box and do things like a close follow-up or maybe a repeat biopsy or an excision biopsy, but ensure that the patient, is not left without giving an answer to the patient. So with that, I would like to conclude. Thanks, Dr. Vishali, for this wonderful opportunity.
Thank you, Dr. Jyoti. It was indeed a great learning experience personally for me as well as I'm sure for the entire audience. And that is when I said that you are one of the dream team members and your presentation proved that absolutely right, that I was correct. And thank you once again for, accommodating our request. We didn't want to let you go without presenting and without, getting your wonderful, learning experience. So thank you so much.
Thank
And
you. Thank
in
you for
case if
inviting
you,
me.
yeah, it's our pleasure always. And we would, in fact, look forward to having you many, many more times on our webinars. So, in case if you are in a need to go and for another presentation, we will allow you. Although
Thank
we
you.
would have loved to have you till the end. But thank you so much once again.
Thank
Uh,
you.
moving on, another stalwart in breast imaging, it's my pleasure to invite Dr. Madhvi Chandra. She is a co-chairperson of Department of Radiology at Sir Gangaram Hospital in Delhi. She is a great mentor to all the budding breast radiologists, a very, very active member of Breast Imaging Society of India. Ma'am has been a faculty at another time in our FSIBC webinars also. We know that mammography is a great tool in our armamentarium, and she's going to take us in a presentation through what are the updates in mammography in today's times. Dr. Madhvi, welcome once again, and over to you. Next
Thanks,
15 minutes
Vaishali.
are yours.
Thank
Thank
you.
you.
Thanks for the kind introduction. I must confess I have not timed this talk and I hope I stick to 15 minutes, but it may go just a bit over.
That's okay. That's okay, ma'am.
So I hope my screen is visible.
Yes, it is.
Okay. Right. So I'm going to be talking about what's new in mammography. So in order to do that, we must first figure out what's old, what is considered old. So the old modalities that we've been using have been screen film mammography and CR mammography. Uh, FFDM is also now pretty old, 2 decades and counting. The newer modalities are digital breast tomosynthesis with synthesized views, contrast enhanced mammography, and now the use of artificial intelligence in mammography. So, screen film mammography has really been the kind of mammography which all of us have used over the last so many decades, and it still exists in our country to a very large measure because it's a reasonable cost to the machine, and we cannot really have a very large capital investment in terms of mammography units because the returns are not that high, and clinics cannot put in this kind of money. So, screen film mammography is also what was used in the West over the last 4 decades. And that is what reduced the mortality due to breast cancer by early detection. So there's nothing that is not doable or usable in screen film mammography, like you can see in these images, which are from 2004. Very early cancers, like you can see this little bit of architectural distortion, and this was a very early DCIS with just foci of microinvasion. They were picked up perfectly well on screen film mammography because the spatial resolution of screen film mammography is very high. So it's a good method of mammography, even though old. And now coming to CR mammography. Now the difference between screen film and CR mammography is that while in screen film you use a hard copy film to acquire the image, in CR mammography it's a phosphor plate, and from that it's read off onto a reading system. And that forms a soft copy. And a lot of clinics have switched to this because they pretend that it's a regular digital mammogram. What happens, however, is that the radiographers that are handling these CR plates, they tend to make the film look nice. They flatten it, they make it a nice gray and white contrast. And because of that, a lot of findings get lost. So the real digital mammography is full field digital mammography. In this, we use a detector consisting of amorphous selenium or silicon or fiber or optic tapers, and this lowers the radiation dose significantly. It has a very wide dynamic range, so a very wide contrast range. And so you eliminate things like film processing, storage, copying, and retrieval. And there's the ability to manipulate images after acquisition. Now, I'm just showing you the difference between CR and full field digital. Now, this is a CR that was acquired at a clinic in May 2023. And I'm sorry, I have a bad cough. So this mammogram was reported as normal. The mammogram does look normal, and the radiologist didn't bother to look at the patient or to take a clinical history because the patient had actually come in with this kind of a nipple erosion. So this was reported as normal. In December 2023, she came to our place and we did a full field digital for her. Now you can see how there are these calcs here. There's a global asymmetry, and that is seen very nicely on this magnified view. This is also a tomosynthesis image that we'll be talking about a little later. So something that was easily detectable in May was lost because this film was flattened out. So that is the problem with CR mammography. So FFDM is the digital mammography that is currently in use. Now, overall diagnostic accuracy between screen film and full field digital mammography does not vary. So if you're using good screen film mammography, that's pretty good. You don't have to worry about not having a digital unit, but try not to use CR mammography because in that you can lose a lot of findings. Then we come to digital breast tomosynthesis. Now, what is DBT? In that, instead of having a fixed tube on your mammography C-arm, the tube actually rotates around the breast, which is fixed in compression on the detector plate, and multiple low dose exposures are taken at multiple angles, which can vary from 15 to 50 degrees. And then thin slices are reconstructed through the breast. So now one, concern in this is that is the radiation dose much higher? Because you're doing both 2D acquisitions and these tomosynthesis slices in the acquisition of a DBT. But we see that if we take a value of X, then screen film mammography and DBT plus full field digital are about the same. Only full field digital is about half the dose of a screen film mammography. Then, there's a thing that we radiologists talk about that's as low as reasonably achievable because we want to give the patient the minimum radiation dose possible. So, instead of acquiring both 2D and 3D mammograms, another thing has been developed that is synthesized views. So in tomosynthesis, you're reconstructing multiple thin slices through the breast. So what they thought of was that they would stack up these thin slices on top of each other and make something like a maximum intensity projection, which is known as the synthesized view, instead of taking a separate 2D view. So if you're not taking the separate 2D view, your radiation dose is effectively halved. And they have found that the synthesized view cancer detection rates are as good as 2D views. So there's not much to choose between them. So this is another development in tomosynthesis, and it helps in cutting the radiation dose. Now, how does, so this is a case contributed by Dr. Sabita Desai, where these are the 2D images and these are the synthesized views. You can see how the synthesized views are actually, looking much sharper than the 2D views, and the findings are much better seen because the Tomo is showing up these findings so much better. And these are being reconstructed into this synthesized view. Now, coming to Tomo versus 2D mammography, Tomo has a lot of advantages. For example, this is a dense breast, And we are not really seeing any finding on the 2D digital mammogram, which is the best kind of mammogram that you can have in 2D imaging. But when we come to 3D, we see this area of architectural distortion, and this was sclerosing adenosis. Similarly, here's another patient, 34 years old, with pain in the left breast. And we can see subtle architectural distortion on the 2D images, but nothing else. However, the moment we go to 3D, we find this large complex sclerosing lesion. So there's the lucent nidus in the middle and long radiating spicules. So that's a finding that was not seen at all on the 2D imaging. So Tomo helps pick up a lot of stuff. Tomo has been around since 2011, so it's been a while that it's been here, 13 years, but it's still a relatively new modality. Then sometimes Tomo helps in finding, in clearing out things that are not really there. For example, this looks like a malignancy. I'm really sorry about all the coughing. So,
No worries, ma'am.
mhm, yeah. So that looks like a malignancy there. But when we go through the Tomo scroll, we see that actually there is nothing there. I couldn't quite believe it because that looked very much like a malignancy. And so I did actually take a repeat view, and you see that there's nothing there at all. So, I would otherwise, if this had shown up on a 2D and I didn't have a tomo, I would have spent a lot of time looking for this on ultrasound. So it saves time for me, improves workplace efficiency. 74-year-old female with a screening mammogram, and we have a focal asymmetry here, focal asymmetry there. Now, on the left, this focal asymmetry turns out to have long radiating spicules. And this was a tubular cancer. On the right, the focal asymmetry turns out to be only an intramammary node. And so we save time. This is a BIRADS 2 finding. We are not worried about this. So Tomo has helped us clear both these focal asymmetries in the same acquisition, that one is clearly benign and one is clearly malignant, instead of having to first go to an ultrasound, etc. All we need to do is ultrasound this with a view to biopsy. Then here's a 51-year-old for a screening mammogram. Relatively dense breasts, but there's a cancer there hiding in plain sight. And there, this is very easily missable, this little asymmetry there, because it's hardly seen on the oblique. But on tomo, it is so evident that you wouldn't miss this cancer. So Tomo really helps radiologists increase their cancer detection rate. Then also, this is a 52-year-old female with a palpable mass in the left breast, and this was diagnosed as a fibroadenoma on ultrasound at a clinic. So it even on the basic mammo, I've just put the zoom over that, forgot to animate this. So it looks pretty circumscribed there. And one would go to ultrasound and think about whether it's a fibroadenoma or not. But on tomo, you see it's higher density. The margins are indistinct, and in fact, even some speculations there. So you're very worried about this. This is a BIRADS 4C finding with or without ultrasound. And on ultrasound, it was solid and irregular. And this was a poorly differentiated invasive carcinoma grade 3 with medullary features. Tomo also helps us localize small lesions. For example, on a screening mammogram, this tiny lesion in the right breast with the tomo slices, we know that it's 12 o'clock middle third, and we easily find it on ultrasound, and we can biopsy this under ultrasound. So it helps us localize lesions perfectly. This is another patient with a very small lesion, 4 mm thing in the left upper outer quadrant, and we know exactly that this is the ML, this is the CC. We know this is 2 o'clock middle third. And we find it very easily on ultrasound and take it to biopsy. So the current status of tomosynthesis is that it's an exciting new development. It has a very high sensitivity, better than 2D mammography, and high specificity, because it helps us avoid a lot of unnecessary biopsies. It's great for localization and helping us find small lesions. The equipment costs are definitely higher, so that's a drawback. The reading time is more, there's a learning curve for radiologists, and there are some limitations in evaluation of microcalcifications or tomosynthesis. Then we come to another new development, that's contrast enhanced mammography. Till now, all the mammograms that we've talked about have depended totally on um, anatomy, on morphology. But contrast enhanced mammography is functional. So it's based on the same principle as MRI, and it depends on tumor neuroangiogenesis with leaky vessels. So in MR also contrast accumulates in the tumor because the leaky vessels permit more contrast to go where a tumor has caused defective vessels to develop. And in this, we use iodinated contrast and dual energy acquisitions and recombined images. So there's non-ionic contrast given, that's 300 milligrams to 370 milligrams per ml and maximum of 150 ml. We preferably use a pressure injector. Image acquisition begins 2 to 2.5 minutes after contrast material injection, and standard CC and MLO views of each breast are acquired at two energy levels. One is the standard, the low energy, which looks like a regular mammograph, that's 25 to 34 kV, and the high energy at 45 to 49 kV. The images are acquired in quick succession while the breast remains compressed, and then there's a recombination. So here's a case shared by Dr. Vinu Singla with me. And there's a patient who had a lump in the right breast for 2 months. So here's a 2D mammography. So there you can see right up outer quadrant, very suspicious BIRADS 5 looking mass and nodes also. So why do we need anything more? Here's the tomo, even better defined. So there you can see the tumors all the way there up outer quadrant. No need of anything further. But the moment we give contrast, you see that the tumor is not limited to the upper outer quadrant, but is also going to the lower half of the breast and also the inner quadrant. So the actual extent of disease is much better defined on functional imaging in like this. This is also known as the poor man's MRI because it's much cheaper, it's much shorter, except for the fact that there's radiation and iodinated contrast. There's nothing to detract from this. Here's another patient again from Vinu, and this is a 42-year-old female who came with awareness of lump involving the right breast for past 3 months. Single mass there, of maybe another there, and nodes. And but on contrast, you see how, you see how there are multiple satellite nodules. That's the large one that was visible, but there are multiple others. So this is a multicentric CA rather than just one big one and a small satellite. And so contrast helps us define the extent of disease, helps us pick up additional disease and sometimes contralateral breast also. Then we come to the use of AI in breast imaging. Now, AI has, come to the fore a lot, and it's being spoken about a lot in breast imaging. So how it works is that at the initial stage, there's a human reader involved who labels mammograms as true positive or true negative, that's benign or malignant. But then the machine reads those mammograms and picks up features which are not evident to us. It can figure out differences in pixels, it can figure out gradients, textures, etc. And that is known as deep learning. Um, so it will pick up features which then are not evident to us and become slightly better depending on the data set it is exposed to at picking up those benign and malignant things. There are many applications of AI in breast imaging, and that can be cancer detection for mammography, decision support, whether something is BIRADS 4, BIRADS 3, risk assessment, breast density quantification, workflow triage, quality evaluation, response to NACT, and image enhancement. So these are a few cases shared thanks to Dr. Nikita Chotai from Singapore. So this is a case where if it came in routine batch screen reading where you have 100 mammograms and you're reading them, you can possibly miss these calcs. But the heat map here on AI shows that there's a 99% chance of malignancy. So these are pleomorphic calcs in ductal distribution. So once you have that bright red thing there, you're not going to miss that cancer at all. So this helps in easy diagnosis and reporting. Now, here's a screening mammogram from 2016. And this was considered by BIRADS 3 because these calcs were considered punctate by the assessing radiologist, and a solitary group of punctate microcalcs can be assessed as BIRADS 3. And she was asked to come on short interval follow-up. She didn't look no, at 2016, AI was not there. AI did a retrospective read later, and this gave a high percentage chance of malignancy. If this had been there, then these would have been looked at more carefully, these calcs. Then she got lost to follow up thanks to COVID and came back for follow up in 2021. And in 2021, at this point, the calcs had spread a lot. There's a full duct that's involved. And this was intermediate grade DCIS with microinvasion. So delay in diagnosis could have been avoided with AI. And then AI works a lot in dense breasts. Let me not go into this busy slide due to shortage of time, but it helps because it picks up cancers in dense breasts. And there are also models in which density is built in as a risk assessment, and AI helps in accurate assessment. Unlike us radiologists, sometimes we say something is heterogeneously dense, sometimes we call it extremely dense, and sometimes there's a lot of different. So this gives us an absolutely accurate assessment. Now, this is a 43-year-old female who came in for a screening mammogram. Now, dense breasts are also very common in Asia. So yeah, it really helps. Now, in this, I would have passed this as normal, and I think a lot of radiologists would have passed this as normal. But AI called this area right 9 o'clock as a 73% chance of malignancy. So this was looked at very carefully on ultrasound, and this kind of a almost non-mass like area was found in the right breast, and this was biopsied, and this was a grade 2 IDC. So AI helps a lot in not in helping us not miss breast cancers. So now these are the new things on the block: contrast enhanced mammography, the use of artificial intelligence as second readers, etc. And we do hope to see all these in wide usage in India. Contrast is, of course, already here, and we hope that AI will also come in a big way. Thank you.
Thank you so much, ma'am. And I'm really sorry, despite your being unwell, you graciously accepted our invitation to join and presented so wonderfully well. It was such a great clarity with which you presented about the updates in mammography. Ma'am, there are certain questions if you feel, you
I'll
know,
answer
if
them in the chat box because
yes,
I think
please.
I
Yeah,
have
yeah.
overrun my
That's what I
time.
was going to
Yeah.
suggest to you. Please answer them in the chat box itself. And thank you so much for joining us.
Thank
And
you.
best wishes for your health now. So let's move on. We will be now inviting Dr. Richa Bansal, who is a great friend, a great asset to the Max Institute. She has been always the first person whom I call when I'm confused about any breast imaging findings. She is going to take us through the ultrasound and help us to understand whether ultrasound can be a complete tool in breast imaging. Dr. Richa, welcome,
Thank you. Thank you for your kind
and
words,
over to
Dr.
you.
Vaishali, and thanks for having me here.
Thank you.
I need to share screen, right?
Yes.
Okay. My screen visible?
Yes. थोड़ा आपका वॉल्यूम बढ़ा दीजिए.
Volume.
हाँ,
अभी ठीक है?
little more,
More?
if possible. Yeah.
Is it okay?
Still not very loud, but will do.
Can you mute it? Can I start?
Yes, you can.
Okay. So, Dr. Vishali, you gave me this visit in complete true or not. So, I go through the uses of ultrasound here in breast imaging because I find it very handy and basically it saves me from a lot of confusion. And then
Oh dear. Dr. Richa, I think there must be some technical problem at her end. We'll wait for a minute or so for her to rejoin. In the meantime, if there are any further questions, please put them in the chat box so that they can be answered.
CA is dynamic and a real-time modality.
Dr. Richa, we are not able to see. Can someone check with Dr. Richa about her?
Dr. Kushi, can you help, please?
Yeah, sure, ma'am.
If she has any technical issues, we can maybe take request Dr. Rishu to present her first, and then just Dr. Richa is calling. So there is definitely a technical issue at her end. Can we request Dr. Ishu Sangal to please, Dr. Ishu, can you start
Yes,
your presentation?
yeah,
Okay.
yeah, it is doable. I hope it works well from my side.
Yeah, yeah. So Dr. Ishu, once again, let me introduce her. Dr. Ishu is our anchor person at Andromeda Cancer Hospital. She is such an expert in all the imaging modalities and definitely a go-to person for all kinds of problems related to breast imaging in particular, and for that matter, all organ-related imaging. So, Dr. Ishu, a request to go ahead with your presentation, please.
Are the slides visible, ma'am?
Yes, they are.
Okay. And am I audible?
You are clear.
Okay, great. Uh, Thank you so much, ma'am, for actually giving me this opportunity. Because actually, this is a great opportunity. I'll be sharing screen space with such breast imaging stalwarts here. And I'm excited as well as very nervous as well. But I'll try my best to do the justice with this. Okay, so I'll be starting with this. I've taken some liberty in the talk. So
Excuse
it
me,
was
ma'am. Sorry for the interruption. Can you please move on the slideshow mode?
yeah, it
आपकी
is on the
last slide दिख
slideshow
रही है
only.
actually.
Okay, it is on the slideshow mode only. Okay, just a second.
नहीं, slide share mode में नहीं था.
Is it okay now?
नहीं, जो नीचे का बटन है ना, ये वाला, उसको दबा दीजिए.
Ma'am, so basically a slideshow from beginning. I'm starting the slideshow, and is it okay now?
No, not
To me,
yet.
the first slide is visible.
Okay. Can you press the button near the right hand corner?
Okay. Is it okay now?
I don't know. But you go ahead, no worries. Dr.
Rishu,
Kushi,
Rishu, what you do is go to the top left, and there's that a green arrow from beginning. Press that.
Ma'am,
It
I'm doing that only. I'm doing that only. Actually, I don't know why I'm able to see it from the first slide only.
Mhm.
Yeah, but it's not on slideshow. But anyway, we can all see the
We
slides.
can
There is
see, we
also
can
a
see.
shortcut at the bottom end, which is a
Hmm.
slideshow button. I'm also pressing that, and it's still, and I'm going to the first slide, but I think it is not visible to you.
That's okay. I think we can move. Please
Okay.
go ahead. Hmm.
Okay, ma'am. So I'll be starting. So I've taken some liberties in this talk. I'll be bit discussing about the basics of the breast MRI, and then we will talk about the updates. So breast MRI, basically the modality, this modality has the highest sensitivity for breast cancer detection among current clinical imaging modalities like mammography and ultrasound. And most of the time, there are two protocols which we talk about when we perform breast MRI, which are the multi-parametric MRI and the abbreviated protocol. So basically, the standard of care and the basically the most clinically used protocol is the multi-parametric protocol. For example, when a surgeon or a clinician orders MRI breast, so this multi-parametric MRI imaging is done. This abbreviated MRI protocol, as the name suggests, it is basically a shorter way of doing MRI, and it utilizes basically the key aspect of breast MRI. So when we talk about multi-parametric MRI, it utilizes all the aspects of MR imaging. It may be contrast, it may be a T2 weighted imaging, diffusion weighted imaging. But when we talk about abbreviated MRI, it utilizes the key aspect, and which is the contrast imaging. So when I have kept this slide because when a surgeon or when a clinician, they do not have the access to breast MRI in their facility, they mostly ask where we can get this done. So basically, when we order a breast MRI, so basically the facility should have all these things. There should be a magnet with field strength of 1.5 Tesla. The center should have a dedicated breast coil. And another thing is dedicated breast radiologist, and I'm sure the first two ones are easily found. This is the most sparsely seen thing. Uh, so coming to the principle of MRI breast, the principle of performing MRI breast is opposite to that of mammography. In mammography, we try to achieve the optimal breast compression when we perform mammography, but when we do MRI, patient lies prone, and the free hanging breast are basically they are seen in the recess of the, they are put in the recess of the breast coil. So basically the breast are free hanging in MRI, while in mammography we achieve the optimal compression. Though the recommendation is also that when a center performs breast MRI, it should be able to do the MR guided interventions as well. But in our country, we see very few centers have that biopsy facility, and we have to refer such patients. So indications for breast MRI are many. So here I have mentioned the three most common ones, the three most common ones used in clinical practice. However, the list is quite big. So it is done for staging in women with known breast cancer. It can be used as a screening tool in high risk women. It is also used for the response to the to see the response to the neoadjuvant chemotherapy. So in neoadjuvant settings, breast MRI is indicated, and so axillary lymph nodes with unknown primary, we also perform breast MRI. That is also an indication, and another is as a problem solving tool. The most common ones in clinical practice are staging purposes, response to neoadjuvant chemotherapy, and screening MRI. So
Dr.
when we,
Ishu, can I, sorry, interrupt you? I don't see your slides are moving.
my slides are not moving.
Yeah, they are
Uh,
not this.
I'm on the slide indications of breast MRI. I'm able to see that. I'm not understanding why it is happening. Mm, So should I change the slide from here? Now you are able to see?
Yeah, it's
Just
indications wala slide.
now you are able to see?
Yes, yes.
Yes, yes.
So should I continue like this without using the slideshow? Okay. Is it okay, ma'am?
Yeah. Okay.
I'm sorry for the trouble.
No worries.
Okay. Okay, so for indications of breast MRI, so see, the first indication is staging in women with known breast cancer. And actually, if we see, we find a big gap. I see a lot of people, they do not actually order breast MRI for staging purposes. Most of the people, they go ahead with PET CT. They do not order MRI because sometimes it is maybe because of the availability, and sometimes we do not see any benefit in this. And why this happens? Because most of the studies, they show no improved disease-free survival or over survival by the use of MRI for the staging purposes. So basically, so just to make it clear, so basically what there are certain indications where we can use it precisely so that we can effectively use this modality, which is women with the breast cancer diagnosis at a young age. So basically, if we see here, we are targeting the aggressive subtype of the breast cancers. So women with the breast cancer diagnosis at a young age, those with an initial cancer manifesting as interval cancer, those with hormone receptor negative cancers or dense breast, and breast conservation without radiation therapy, and when the histopathology is invasive lobular cancer. In such patients, it is recommended that we should perform staging with breast MRI. And it is also known that for the size estimation, contrast MRI breast is the best modality. And especially this is seen in the invasive lobular cancers, ductal component with IDC, and high-grade DCIS. So coming to the first thing, which is multi-parametric MRI, it is multi-parametric MRI. So basically, as I said, it utilizes all the sequences available to us so that we can do a good lesion detection as well as characterization. So first of all, I'll be talking about this contrast enhanced sequence. With the main purpose of this contrast enhanced sequence is the lesion detection, because all the MRI lexicon is based on the enhancing part of the lesion. So in this contrast enhanced, so basically how does it start? We perform a baseline, a T1 weighted image, basic T1 weighted image without a contrast. And then we obtain a series of T1 weighted images between 5 to 7 minutes after the contrast material administration. We get certain curves, and we can evaluate those curves with the by doing the visual assessment or the color map overlay. So if you can see this image, this is the visual assessment we can do here, and this is the color map overlay. So here we can see that there is an enhancing lesion here in this A image here in the posterior part of the breast. And then if we see, this is a delayed enhancement image, and here we can see it is smudging. It is basically not standing out from the background enhancement. And then here we can see the image C, where we can see this color overlay. Here we can see this invasive component as red, and there is associated non-mass enhancement, which is seen in the green color, which is showing persistent kind of kinetics. And if we see here on those contrast images, this non-mass enhancement, if we just do the visual assessment, we are able to see there is some kind of progressive enhancement, type 1 enhancement kinetics. But when we see on the C image, where we can see the color map overlay, we can see some yellow dots and red dots here, which show that then there are certain areas of the washout kinetics and the type 2 plateau curve as well. So which makes it more suspicious. So color map overlay basically gives us some more objectivity. Again, this is basically this visual assessment we can do here, a non-contrast image, early contrast image, and the late contrast image. And here we can see a very well enhancing lesion, which is fading out in the delayed phase. So this is basically the curves we all know, persistent, plateau, and washout curves. So type 1 curve is the persistent curve, which is mostly seen in the benign lesions. Type 2 is the plateau. Basically, it can be seen in both benign and malignant. However, it is more associated with the malignant lesions. And type 3 is the washout curve, which is very, most of the malignant lesions shows this washout curve. So 85% of malignant cancers, they generally show the washout curves. It is highly sensitive for the detection of malignancy. So there was a retrospective study which actually studied these type 2 dynamic curves, and when they said that the conclusion was that actually this slide is not working, the slideshow, the conclusion was that that most of the lesions which showed type 2 dynamic curves, they were malignant lesions more than benign. And the most frequently encountered benign lesion with type 2 dynamic curve was the sclerosing adenosis. Other two sequences for lesion characterization are the so part of multiparametric MRI only. We also perform T2 weighted imaging and diffusion weighted imaging. Though in my order, I actually described the contrast MRI first, and then I'm talking about the T2 weighted imaging and diffusion weighted images. But normally in practice, we perform the non-contrast sequences first, T1 weighted, T2 weighted, diffusion weighted, and then we perform the contrast imaging. The purpose of T2 weighted imaging and diffusion weighted imaging is to characterize that enhancing lesion. These help us in characterizing. Basically, role of T2 weighted imaging. So we say that there is a saying that basically T2 weight, mostly benign lesions are hyperintense on T2 weighted images, and malignant lesions are mostly T2 hypointense. So these are not exclusive categories. There are certain exceptions to that as well. Some benign, there are certain necrotic cancers, mucinous carcinomas, and metaplastic carcinomas, which may be hyperintense on T2. And there are also certain malignant lesions, which there are also certain benign lesions, which may be T2 hypointense. So we have to use these criteria together. I mean, we have to add them and then decide, and not based on a single criteria. We should actually give a Barrett's category. So the purpose of characterization is that we give the right Barrett's category to the lesion. Also, the role of T2 weighted imaging is to see the perifocal or prepectoral edema, which tilts the diagnosis towards the malignancy. So these are the lesions which are hyperintense on T2, these benign lesions. Diffusion weighted imaging, the role of diffusion weighted imaging is again to characterize the malignant lesion. And so basically why this sequence is very much preferred, because it has a very good sensitivity and specificity for characterizing a benign and malignant lesion, and it has a very fast acquisition time. It normally takes 2 to 3 minutes to acquire this image, and there is no requirement of contrast administration, which makes it one of the most studied sequence in MRI protocols. So basically, now there is another sequence, which is basically the diffusion sequence only. Here we are basically quantifying this property of water molecule, giving it a value, giving it more objectivity. And those values are usually expressed in 10 raised to the power 3 millimeter square per second. And basically, it is also used for the study and research purposes. So if we go about the ADC values, the values are generally, I'm sorry, I think I missed it. Yeah, the values are generally low for malignant lesions and high for benign lesions. However, there is some overlap as well. But for malignant lesions, the values generally range between 0.8 to 1.3. For benign lesions, the values range between 1.2 to 2. However, if we talk about the clinical practice, we do more of the eyeballing. So such lesions which are malignant, they look hyperintense on diffusion weighted imaging, and they look hypointense on ADC. So this is an example. So here if we see left breast, there is a enhancing lesion, heterogeneous enhancing lesion in the posterior part of the left breast. And this is the diffusion weighted sequence. And on the side, this is the ADC sequence. If we see here, this is the bright on diffusion weighted imaging, and this particular lesion is hypointense on ADC. So breast MRI report, it should contain basically standard report should contain clinical indication. It should talk about the protocol, what sequences we applied, how the post-processing was done, what was the contrast agent dose and type, which it should also describe amongst the findings that what is the breast composition, how is the background parenchymal enhancement, how was the morphology, and then it should describe the morphology and kinetic features of the lesion in question as per Barrett's lexicon. And then the report should have a final Barrett's category. This is how a MRI report should be made. So for actually assigning the Barrett's category, there is also a Barrett's lexicon for the MRI findings. There are certain morphologic depictors as well as kinetic depictors. For the morphologic depictors, the findings are to be categorized into one of these three categories, either a focus, mass, or non-mass enhancement. So there are certain more descriptors how a mass should be described. We should describe the shape, margins, internal enhancement pattern for the mass. For non-mass like enhancement, we should describe the symmetry or asymmetry, the distribution pattern, and the internal enhancement pattern. So these MRI, these descriptors should be used while making the report. So when we come to the, so those were the morphologic depictors, and these are the kinetic descriptors. So when we give the contrast, there is an initial phase of contrast enhancement as we saw in the previous curve, and then there is a delayed phase of contrast enhancement. So the descriptor for the enhancement kinetics is based on two different phases, the initial phase and the delayed phase. The kinetics showing rapid initial enhancement followed by washout or plateau is suspicious of malignancy, while the lesion showing a medium or slow early enhancement and on delayed phase showing persistent enhancement, they are more likely benign. As I said, these are not exclusive categories, but it is more likely of a benign lesion. We have to take care of the morphologic descriptors as well. So this is a very nice slide. Actually, we do not have much of the time here, so I'll not go into the details of this slide, but this was a very nice slide. So the kinetic descriptors are not only used for the diagnostic purpose, we can use in the post-chemotherapy breast MRI as well. And here, as you can see, so early phase of dynamic contrast enhanced MRI is very useful for response monitoring following chemotherapy and prediction of pathologic complete response. And the delayed phase of dynamic contrast MRI, basically it helps us to see the residual tumor extent. And there is also, second point is also very interesting. Early phase is very good for seeing the invasive tumor size alone, and the use of delayed phase is basically the size of invasive tumor with in situ tumor can be seen. As I told, basically ductal carcinomas, they sometimes show those persistent kind of those progressive kind of enhancement kinetics, and they enhance in the delayed phase. Now coming to the abbreviated breast MRI. So abbreviated breast MRI, if I say we do not do it routinely in our practice, but there are a lot of papers on this, and we hear about it in a lot of international lectures. And because from where this need of abbreviated breast MRI came, basically it has been recommended that breast MRI should be used for screening in the high risk category women. And though we do not have any such screening programs in our country, so that's why we do not use it as often. As often we use multi-parametric breast MRIs. The idea of this sequence is to extract maximum information out of minimum pulse sequences. And why we need this sequence? Because if we want to use it for screening purposes, we need to make it cheaper. We need it should take less time to understand, to read, and the patient should also spend less time inside the gantry so that we can make it comfortable for the patient. And when we think about the most important pulse sequence of breast MRI, it is the contrast sequence. We cannot imagine a breast MRI without a contrast sequence. So basically, it's not 70 minutes, it's the first 60 seconds in breast MRI, which are the most important when we talk about the abbreviated breast MRI. So abbreviated breast MRI, basically, there are different kind of protocols that have come up, and sometimes we get confused what protocol to use, what is actually abbreviated breast MRI. So basically those protocols can be characterized, categorized into three types. So basically there is a very beautiful paper from Kul et al. So it was published in 2024 only. This is a very recent paper, and they have categorized these protocols into three parts. So first is the short protocol, which actually came into work and which actually was recommended for performing the abbreviated breast MRI. Here we perform the contrast sequences only, and the contrast sequence, so basically a non-contrast sequence and a contrast sequence in the first 60 seconds. We either use the fast sequences or the ultra fast sequences. Then there is another type of protocol, a bridge protocol, where we use the contrast sequences as well as the non-contrast sequences. And we try to take, so we do a 1 minute fast or ultra fast sequence, post-contrast administration. We can add T2 weighted imaging with it. Some people add additional dynamic phase to it, or some people may add diffusion weighted image to it. So they take few of the pulse sequences from the multi-parametric MRI protocol, and they have devised this bridge protocol. So basically the advantage of doing additional dynamic phase is again that, so DCIS and low grade invasive cancers, which we may miss on the just 1 minute protocol, they can be detected by using this. And the washout also helps us to differentiate from fibroadenoma, because it is rare to see a washout in the fibroadenoma. Then third is the abridged non-contrast protocol. Basically, a lot of papers are going on for this, but there is no clear indication of using it for that purpose. So diffusion weighted imaging, and it basically utilizes the diffusion weighted imaging and T2 weighted imaging. And why there is so much of interest in this? Because it has, because no contrast administration is done in this, and that's why there is low cost for this. So basically, anything that is shorter in duration to MRI is considered to be abbreviated breast MRI. But the protocols, this short protocol and the average protocol, they are the preferred ones for the abbreviated breast MRI. So what is the difference between fast and ultra fast MRI? So that's quite interesting to understand. So basically, fast MRI here, images are acquired every second. So one frame where we image whole breast, that one frame is completed in 60 seconds. That's why the spatial resolution is very high and the temporal resolution of the images is low. So basically, it takes more time, but the clarity, the resolution is higher. For ultra-fast MRI, we acquire continuous images of contrast washing for approximately 60 to 120 seconds. So we get every 3 to 4 seconds, one frame is acquired. The whole breast is imaged in 3 to 4 seconds after contrast administration. If we talk about the whole total acquisition time, it remains same for both fast MRI as well as ultra-fast MRI. As the name suggests, it is not faster in terms of, ultra-fast MRI is not faster in terms of total acquisition time. So the fast and ultra fast MRI require about the same acquisition time. Both are required before and during the early post contrast phase, during which either a single high spatial resolution image is generated or many lower resolution images are generated. So this is I actually took this image from that paper only, and this is very beautifully described. I'll show it on the next slide. Here it might be visible, well visible. So this is the concept of ultra fast MRI. We are taking multiple images like this. Post administration of contrast, we see the contrast in the heart and we see it in the thoracic aorta. Then we see that there is some enhancement in the lesion and so on. So when we see the ultra fast MRI, so this is the comparison, head-on comparison for the same lesion performing the ultra fast MRI, and this is the DC MRI where the spatial resolution is high and here the temporal resolution is high. That means we can take many images here during that initial 60 seconds or 120 seconds. So if we see the lesion here, this is the ultra fast MRI. The lesion is slightly enhancing here. Here also we can see the lesion. But if we talk about the margins of the lesion, we can see them better in the dynamic contrast MRI. So basically normally fast MRI. And here the lesions are slightly, the margins are slightly blurred. Again, this is a subtracted image. We can see the clarity is much more in this fast MRI. So this is the point they wanted to make from this, is that so fast MRI, which we have been doing. So what we were doing at our center, we were also doing the fast MRI. Ultra fast MRI is available is mostly with the new machines, with newer softwares. And though and it is not so if you are performing it with fast MRI, you are performing anything wrong. This is also, though the new thing is ultra fast MRI, but even with the fast MRI, you get the similar kind of information. So coming to the accuracy of abbreviated breast MRI, so that they basically, so there are many meta-analysis, there are many studies which have been done, and they say that for both short and abridged protocols, the protocols which were using the contrast, it is same as that of multi-parametric MRI. And when they say that, the question that comes to our mind is that why we need multi-parametric MRI then? So there is no clear answer to that, but maybe it is because we have been doing this for such a long time. It gives us more confidence. And however, there were also not clear-cut studies which were comparing them in the real clinical scenario. They were mostly in the research settings. But now ongoing studies are also there which are comparing abbreviated MRI and multi-parametric MRI in real clinical scenarios. And there are certain results, some interim results are also there. So basically, they have compared them across the three categories for the screening purposes, for the post BCS patients, and for the diagnostic assessment. And there is a study which is EA1141 study, where for the screening purposes, they saw the results between the multi-parametric MRI and the abbreviated MRI. They are quite comparable. They are very much comparable. And for post BCS cases, the results are favorable for abbreviated MRI with higher specificity and positive predictive value. For the diagnostic assessment, they need more data. So basically, we have to wait for the results. So this was about the abbreviated MRI, which is the basically which is a newer protocol, and we talked about multi-parametric MRI as well. So these are the take-home points from this talk. Basically, multiparametric MRI, it utilizes all the aspects of MRI imaging and is the standard of care in our clinical practice. Abbreviated MRI utilizes key aspect, which is the contrast imaging. Accuracy of abbreviated MRI is comparable to multiparametric MRI across many studies. And MRI breast should be reported as per the Barrett's lexicon. And to utilize breast MRI to improve clinical outcomes, the information needs to be communicated well to the clinicians, and MRI guided interventions should also be readily available. Thank you.
Thanks, Dr. Rishu, for helping me out there when Dr. Richa was not able to present. Thank you so much. And I'm sure with when the experience we gather the experience, these newer protocols, abbreviated and abridged protocols, can be of clinical help for us. And it can make the MRI study more economical and more useful for the clinicians as well. So thank you so much for joining us today. We will
Thank you.
now come back to Dr. Richa. Dr. Khushi, Dr. Richa is yet to finish. Dr. Richa has joined us. Dr. Richa, over to you. We can see your slides, but you are muted.
Okay. Am I audible?
You are. You are.
We'll continue with the indications of ultrasound. So, ultrasound is the first line of investigation for women less than 30 years of age, and main indications are in lump, evaluation of lump, pain, and nipple discharge. And it also helps us in characterization of abnormalities which are detected on mammograms and MRI, such as masses, focal asymmetries, and architectural distortions. It helps in follow-up of patients on NACT. In our clinical practice, we are routinely doing ultrasound mainly for follow-up of patients on NACT for assessment of masses and axillary nodes, except in some cases of non-mass enhancements initially detected where MRI is mainly used. Ultrasound is a great imaging modality for guided interventions. It helps in second look ultrasound. It helps in detection of lesions, additional lesions detected on MRI, and it can be used as an initial imaging modality for evaluation of breast implants. As far as screening is concerned, ultrasound is not the modality of choice for screening of breast ultrasound, except in cases of high risk women less than 30 years of age. We can use ultrasound. But nowadays, since MRI has come up as an alternate modality, so people prefer to use MRI for these women. In women with dense breasts, extremely dense breasts, we can't see anything much on mammogram. Ultrasound helps in such cases to some extent. In cases of generalized breast pain, generally these are cyclical pains, and ultrasound, it can be used as a screening to rule out any abnormality or just physiological changes in the breast. Color Doppler we use with ultrasound. It helps in to some extent, helps in addition to morphology of the lesions, like the malignant lesions have deep penetrating vessels within them. In intraductal lesions, it helps in distinguishing between the intraductal contents and papillomas. Papillomas show distinct vascularity within them, while the intraductal inspissated contents, which may at times look like papilloma, do not have any much vascularity. So when it comes to characterization of breast masses, first, as soon as we see a mass on the mammography and we do an ultrasound, the first thing it helps us to know whether it's a cyst or a solid lesion. Helps in further characterization of the cysts as simple, complicated, or complex cysts, such as complicated cysts are maybe cysts filled with internal echoes, or smoothly thin walled cysts are characterized as complicated cysts. These may be left alone or may be aspirated if the patient is symptomatic. But complex cysts on ultrasound are seen as cystic areas with echogenic solid nodular components, like in this case, and this is a corresponding MR of this patient which shows an enhancing nodular lesion within a cyst, and biopsy showed it to be an intracystic papillary lesion. When it comes to masses, it helps us in distinguishing between benign and malignant masses to a large extent. So most common benign masses in breasts are fibroadenomas, smoothly marginated, oval, hypoechoic lesions, parallelly oriented, wider than tall, no significant posterior shadowing is seen. Lipomas in the breast are incidentally detected lesions. And breast hematomas. Breast hematomas or fibroadenoma or breast within a breast lesions which show areas of hypoechogenicity, isoechoic as well as fat components within them. So these are the most common benign lesions, and if we see these benign lesions, mostly we can just leave them alone and keep them under follow-up. Presence of these slit-like cystic areas within a uh, fibroadenoma kind of a lesion or some fluid components or sudden increase in size of the lesion may indicate the presence of a phyllodes tumor. Malignant lesions on ultrasound are seen as with irregular hypoechoic lesions, either with dense desmoplastic reaction within them or with dense posterior acoustic shadowings. So once we see these lesions, there is hardly any doubt. We don't need any further investigation, at least for this primary lesion, and it can be easily biopsied under ultrasound guidance. The second, uh, the second indication of breast ultrasound is mainly nipple discharge and ductal pathologies. So, nipple discharge can be physiological lactational. The normal ductal diameter in breast is 2 to 3 mm, and any prominence of the duct more than 2 to 3 mm is referred to as ductal dilatation. It may be seen physiologically in lactating patients. Duct ectasia refers to retroareolar ductal dilatation. It can be due to inflammatory process due to blocked ducts or in some cases of infections or mastitis. And in cases of neoplasm, there can be intraductal papillomas, which are generally benign neoplasms, or in malignancies, which can be DCIS or IDC. So this is how a normal ductal system looks on ultrasound: smoothly tapering anechoic tubular structures without any intraductal contents. Intraductal contents, when we see, as in this case, normally in cases of maybe periductal or periductal mastitis, some patients have intraductal content which are echogenic. Sometimes mobility may be seen in these contents. There is no vascularity is seen within these contents, and mostly there is vascularity seen along the ducts. And if we do an corresponding MRI for these patients, it shows dilated ducts, which may show some T1 thick contents but without any significant intraductal enhancement. Intraductal papillomas, as in this case, are seen as lobulated intraductal lesions with internal vascularity. In some cases, we may not be able to demonstrate vascularity in a papillomas if the probe pressure is too hard or due to some technical problems. This was an interesting case, in which we can see on ultrasound there is a focally thickened duct with intraductal calcifications. Corresponding mammogram shows a focal linear area of, pleomorphic microcalcification in this location. And on MRI, we see there's a thickened duct with diffuse duct thickening and enhancement, and biopsy showed it to be a DCIS. So even the malignancy can be well demonstrated on ultrasound. We can see intraductal calcifications. We can see periductal masses, as is in these cases. It may be associated with ductal thickening and irregular hypoechoic masses in association with the thickened ducts. So the features which favor malignant process includes peripheral location of the thickened or a dilated duct, irregularity and thickening of the duct wall, and presence of an adjacent hypoechoic mass. So all these features on ultrasound favor a malignant process and warrants a biopsy. The third most common indication for doing an ultrasound is a pain in the breast. So a lot of young women especially come to us for ultrasound breast for breast pain, and in these cases, ultrasound is a great modality. Normally, it's a cyclical bilateral pain, and we have no specific findings are seen on ultrasound. And the other cause of pain is mastitis, or which may be inflammatory or infectious mastitis. So the breast pain may be due to presence of complicated cysts, or sometimes the pain is very superficial and we see just a subcutaneous or a cutaneous lesion or an epidermal inclusion cyst, which can be seen on ultrasound as a subcutaneous hypoechoic lesion. Sometimes there is thrombophlebitis of the superficial veins, which is labeled as Monder's disease. All these cases cause specific localized breast pains and can be well demonstrated and diagnosed on ultrasound. Acute mastitis may be periductal mastitis or parenchymal mastitis. Periductal mastitis is mainly seen as areas of ductal dilatation, subareolar abscesses, intraductal contents within the ducts, and surrounding edematous changes. While intramammary infections are seen either area of edema, patient will come as diffuse pain, and we on ultrasound we see diffuse edema in the area of the breast, or it may be seen as acute abscess, thick contents within the collection, which can be further aspirated. The other chronic mastitis, coming to chronic mastitis, there are many causes of chronic mastitis. I'll not go into the details. I'll just come to idiopathic granulomatous mastitis, which is, I think, an ISO for all of us. But ultrasound has very specific findings of idiopathic granulomatous mastitis, and these findings actually point to a diagnosis and makes life easier, at least from the diagnostic point of view. And we see that there are irregular hypoechoic collections within the breast. We see them interconnecting with each other, and there are linear track-like areas which extend up to the skin, and there are subcutaneous abscesses always forming. So this was a case in which patient presented with a lump in the breast. If you see the mammogram, there is an irregular isodense mass which is seen in the upper central region. Patient didn't have any significant pain or tenderness. But when I did the ultrasound shows the very specific findings of granulomatous mastitis. There were irregular hypoechoic collections in the breast. The parenchymal lobules were all dense. There was a linear track extending up to the skin. There was no pus as such which could be aspirated, but biopsy shows IgM or idiopathic granulomatous mastitis. So in some cases, actually, ultrasound, if not say the complete tool, but it is definitely a great tool for diagnosis. Targeted ultrasound is the term we use basically to when we do an ultrasound for a specific finding on a mammogram, or we use the term second look ultrasound when we use it to visualize the findings seen on MRI. So basically for targeted ultrasound, review of a prior imaging findings is very important. The patient position is very different between ultrasound, mammogram and MRI. So the lesion location may be affected by the patient's position, and the person doing the ultrasound has to be careful that he or she is looking at that specific lesion for this which it is targeted to. So this was a 40-year-old female who came first for PHP or a health checkup ultrasound for mammogram, and on mammogram it showed an area of architectural distortion, and there was some tiny gastric foci which were seen in this location. Targeted ultrasound of the area showed an irregular hypoechoic, a non-mass like area of involvement, and I did the biopsy of this lesion. The report hasn't come yet. It was a recent case. I'll share it whenever I have it. So this was a second look ultrasound. This was a patient who presented with a retrorural lump in her left breast. This was a case, and on MR we saw there was another lesion which was seen superolaterally. A second look ultrasound showed a lesion in the primary or the index lesion, and this little nodule, when seen carefully, was detected seen well on ultrasound at a distance of approximately 2 centimeter from the index lesion. It was FNA'd and it came out to be positive for malignancy. Another similar case, there was an irregular spiculated mass in upper central region of left breast, and besides that there were these two, three satellite nodules which were seen. Second look ultrasound, the nodules were very well detected, and they were JY localized and further excised. So coming to elastography is basically an adjunct to improve the specificity of grayscale ultrasound. So elastography is based on the fact that malignant lesions are stiffer than the benign lesions, which is contributed by the desmoplastic reaction, infiltration of the adjacent component of the interstitial tissues. So the malignant lesions tend to be more hard than the benign lesions. So whenever we do elastography, there is this scale on the left hand upper corner, which from blue to red, from soft to hard. So So as we see, this is an smoothly marginated hypoechoic lesion consistent with a fibroadenoma in the breast and elastogram. We see that it is blue or a soft lesion. We can also take strain value or there is a specific value which we take. Even in this lesion, it is intermediately soft and shows green. This was a case of a malignant lesion. We can see the lesion is oval, although it is wider than taller. But when we did an elastogram, the center of the lesion is pretty hard. The surrounding is relatively soft, and biopsy was a biopsy proven IDC. Another example of a malignant lesion, the lesion looks relatively smaller on the grayscale ultrasound, but the area of hardness around it was more than the actual lesion seen on ultrasound, showing this associated desmoplastic reaction around it. Similarly, a small lesion with a large area of hardness and desmoplastic reaction around it. So the clinical applications of elastography is that is may downgrade a Barrett's 4 lesion to Barrett's 3 lesions, especially in cases of a complicated cyst. It may even helps in upgrading the lesion from Barrett's 3 to Barrett's 4. It helps in characterization of small incidental masses detected on screening mammogram or on MRI. Especially, this was a case, it was a very tiny little lesion which was detected on mammogram. On ultrasound, we see a small hypoechoic lesion with area of shadowing in the posterior depth of the breast. On elastography, we see that this is associated with this area is quite hard with a high strain value. So it's as an adjunct to increasing the specificity. The other main application which I found was in helping to assess the area from which to biopsy a lesion. So this was a case of a triple negative breast cancer. On grayscale ultrasound, the entire area looks hypoechoic with small cystic internal necrotic areas. However, in elastogram, we see that mostly the center is very soft, indicating the necrotic areas, and the periphery is hard, which is the solid component, and therefore the biopsy can be targeted from the peripheral parts of the lesion. Ultrasound in pregnancy and lactation. Ultrasound is the modality of choice in these cases due to reduced mammography sensitivity. The most common abnormalities detected are infection, galactoseals, lactating adenomas, and infarctions or cystic changes in a fibroadenoma. And any newly diagnosed palpable mass during pregnancy should be looked up on ultrasound and, if possible, biopsy. So this is how a different appearance of a galactosele may be seen. It may be purely cystic with some floating fat densities within it. It may show a fluid level. And even a galactosele may appear more solid and more organized, in which it is difficult to differentiate it from a solid lesion. And then in some cases, we need to biopsy even a galactosele. Male breast ultrasound, we get a lot of requests for male breast ultrasound because of the unilateral or bilateral gynecomastia. So this is a case of a gynecomastia. This is the left breast, this is the nipple, and we see that the normal fatty areas are seen around the nipple, while on the right side, unilateral gynecomastia, this branching hypoechoic glandular pattern is seen, and we can easily diagnose as a gynecomastia. Male breast cancer is mostly eccentric in location. The appearances are same as breast cancer in women. Imaging of the axilla, ultrasound imaging of the axilla is an imperative part of breast ultrasound. And I think ultrasound, I personally find ultrasound as the most specific modality for characterizing the axillary nodes. So this is a normal axillary node, which is with maintained fatty hilum, and this is normal cortical thickness. With progressive infiltration from malignancy, we can see there may be eccentric thickening of the cortex, there may be complete loss of fatty hilum. And in some cases, even if the node is small, the loss of fatty hilum and rounding of shape indicates that it might be involved by the tumor. This was a retropectoral node, which was well seen on ultrasound. So ultrasound can be used for evaluation of breast implants, initial modality. So this is how a breast implant looks like. This is the implant capsule, and this is a normal fibrous reaction around the implant. These are the normal radial folds within the implant. I'll not go into the details of the implant. Post-treatment imaging and post-treatment follow-up. Ultrasound shows presence of seromas, presence of Postoperative scars can be well seen. Mostly areas of sometimes women present with hardness in the breast at the site of the scar. Ultrasound shows that areas of fat necrosis, which are seen as areas of variable echogenicity. But if they are adjacent to the scars, it may be seen with some fluid level or a cystic areas with eccentric echogenic component, and the patient can be well assured that it is not a recurrence. It only sometimes happens that we are not able to distinguish between a recurrence and a scar. In those cases, patient is referred for MR. Ultrasound guided interventions. So we all do ultrasound guided biopsies and FNACs. It's used for JY placement in post chemotherapy patients or in primary resection of tumors in non-palpable tumors. Clip placements are done under ultrasound guidance prior to NACT and for guided aspiration of seromas or abscesses. So this was a lesion in which the clip was placed prior to chemotherapy. The region has shrunken in size, and then the JY was placed under ultrasound guidance for lesion resection. Coming to some newer developments, so 3D ultrasound. In 3D ultrasound, with a single pass of the ultrasound beam, a 3D reconstructed image can be formed in coronal, sagittal, and transverse plane. So it basically allows an accurate assessment of anatomical structures and tumor margins. 3D ultrasound may also be used in addition to CT for image guided radiation therapy. Automated whole breast ultrasound. In automated whole breast ultrasound, basically more than approximately 3,000 overlapping images are obtained, and basically they are reviewed later by the radiologist with associated 3D reconstruction. The advantages include less operator dependence, of course, increased radiologist efficiency, and aid in follow-up studies. But it is also at disadvantages in the sense that sometimes there is a limited ability to scan the entire breast, particularly the posterior margins. It is time consuming to review so many images by the radiologist, and the need to recall patients for a second ultrasound for evaluation of indeterminate findings. Contrast enhanced ultrasound is again being explored to enhance ultrasound diagnosis, but now contrast enhanced mammography is playing a great role in detection of multiple lesions. Fusion imaging involves direct overlay of correlative MR imaging with targeted ultrasounds. And we also have in some machines, like in our Samsung machine, we have ultrasound CAD. So this is the application which is available in Samsung machine in name of S Detect. So what happens in S Detect is we localize the lesion, and when we localize the lesion, we draw a margin of the lesion, and then the CAD detects the lesion, studies its shape, orientation, margin, and gives a independent Biret score. So basically, it helps the operator to improve the accuracy of lesion characterization. Ultrasound definitely has some limitations. A large fatty breast, ultrasound should never be employed as the only modality. Microcalcifications, mammography is the gold standard. And it is a subjective exam that depends on the skill of the single operator. So all modalities must be employed in the most appropriate way to cover the diagnostic needs of each single patient. So now Dr. Vaishali will let us know whether it is not a complete tool, but it is a great tool. It really comes in handy.
Indeed, I think I would say that with an expert people like the faculty members present here today, ultrasound actually solves most of our mysteries, and we may not need, high-end investigations like MRI, which may not be available in most of the centers. So, although it may not be a complete tool, but in many of the cases, especially the ductal assessment, whether it is a solid mass or a cystic mass, for doing simple breast interventions, ultrasound comes as a very, very handy tool for all of us. So thank you, Dr. Richa, for being with us and presenting the vast, indications of breast ultrasound. Now we move on to the most awaited session of this webinar. For that, I would like to invite Dr. Janki PD, who is again one of the most respected breast imaging expert in our country and a dear friend too. She also is a passionate teacher. I can see her share many, intriguing cases in the BC group, and she definitely tries to teach the new, radiologists who are trying to try their hand on breast imaging. So over to you, Dr. Janki, for presenting the challenging cases. Thank you so much for joining us.
Okay, am I audible?
Yes, you are.
Yeah. Okay. So now over to the last portion of today's lectures, and thanks Dr. Vaishali for organizing the series of lectures. And today happens to be our 8th November is the World Radiology Day. So
Yes,
thanks for giving
indeed.
me an opportunity for presenting the topic very close to my heart.
Thank you.
And so we'll be just going through the second set of challenging cases. Dr. Jyoti has already covered the initial set, so I'll be going through a slightly different kind of cases. So coming straight and already in the previous lectures, we already have got an idea regarding the modalities that we use for breast imaging. And only when we are able to use all the imaging, we'll be able to come to a conclusion. And it's not just the radiologist, the team consists of a radiologist, the surgeon, the pathologist. With these three are the pillars of any breast examination. Without that, it's totally incomplete. So in the case one, we had a 40-year-old lady who had presented for baseline opportunistic screening. Because in India, since we don't have proper screening, we just do call it as an opportunistic screening and make sure that she does ultrasound also in the same sitting. So when we inquired, she told that at least 4 members in her family have got breast and ovarian neoplasm, but she did not have any concerns at the time of examination. So these are the mammography images. So already Dr. Madhvi has mentioned about the CR as well as the digital FFDM. So these are actually the CR images. We are just able to make it out, but not exactly means we are able to. It's a very dense breast, and we see that the left breast is unremarkable. But on close examination, we found out that there is a subtle lesion in the right breast that is almost close to the retromammary fat.
Ma'am, your
Dr.
slides
Janki,
are
your
not
slides are not visible.
It's not visible.
They're not moving.
I'm sharing. Okay. Is it moving now?
No, we can't see the screen yet.
It's coming as the screen is being paused.
Can you can the Mice Ideas people help her?
Yeah, sure, ma'am. So, ma'am, what is the issue?
She is not able to share again. So can you help her? What must have been the problem?
Yes, ma'am, I understand. So, ma'am, could you please share your slide to me? I'll share it from my end.
Did you press stop share, Dr. Janki?
Yeah, I already pressed.
Okay. Now please click on the share again. Yeah, we are able to see the screen now, but not the PPT.
No?
Yes, yes. Abhi, go to the, yeah, now
It's
perfect.
moving?
Yeah.
Yeah,
It's
okay.
moving.
Yeah, got it.
Correct.
Yeah. Okay. So this is the first case, that is heterogeneously dense breast composition. Left breast was unremarkable, and these are the CR images. So the chances of missing out the information on CR image is very high. So that is why even if a patient comes also, if they're coming with these kind of images, we usually ask them to repeat the images. But in this one also, we are able to make out that there's a small lump that we are able to see along the retromammary fat. Okay, so these are the zoomed up images. So we know that there is a mass behind, and the margins are partially circumscribed. So there's an oval mass with partially circumscribed margins in the right breast around 12 o'clock position in zone C, that is located far posteriorly. And for this, we proceeded with bilateral breast ultrasound, but what we found out was she was having bilateral multiple simple cysts. But one of the lesion at 12 o'clock position about 3 centimeters from the nipple, that was located far posteriorly. So it does look anechoic, but we are not very comfortable with the margins. So it is does not exactly fit into a simple cyst. So we know this has to be worked up further. So there's a single hypoechoic mass with indistinct margins, taller than wider, and that does not show any vascularity and no shadowing. So what is the next step? So we know she's a young lady, dense breast. She has got multiple family members and with the CA breast. So definitely she falls into the high risk. So these are the shear wave elastography images. And this also showed a relatively soft mass. The consistency was quite soft and it is homogeneous. So what do we do now? We proceeded with the mass was definitely looking suspicious. So we actually proceeded with MRI breast. We explained the things to her. We told we explained the things to the surgeon. We told her we have to characterize the mass and exclude a multifocal disease. So proceeded with MRI breast. And what we saw was this was a mass present over here. It was having some is slightly bright in the center. So what we thought was okay, it can be an intramammary lymph node. That was the first initial impression that we got. It is bright on T2. So normal mistake away is if a lesion is bright on T2, then the chance of it being malignant is less. Is just 10%. So this lesion was particular lesion was bright on T2. We did diffusion weighted sequences, and what we saw was it showed the restriction. There was restriction on diffusion weighted sequences, and then these were the dynamic contrast images. So this is the plain image. Then after that, we are seeing this the initial pass, and where it is enhancing rapidly, and this is a delayed phase where it is actually washing out. So we have got a single lesion that is suspicious, and here we can almost see that the margins are slightly irregular, and what we are seeing in the center may be just some necrotic area. There's a possibility. So unifocal mass. So what's the next step? We proceeded with ultrasound guided biopsy for the mass. The maximum size was 6 millimeter. So if you are confident enough, we can just go ahead with the ultrasound guided core biopsy. And it turned out to be invasive breast carcinoma grade 2, and IHC breast panel was performed. So that was ER positive, PR negative. It's actually luminal B. So now we have found out. So even we have found out that the lady, she has got a screening detected mass. It is unifocal. The size is less than 6 millimeters, around 6 millimeters, and it is malignant. She has got a luminal B, and her lymph nodes were looking normal. So all this information we are able to give to the surgeon before she goes in for the surgery. And meanwhile, she also got a BRCA1 mutation. Later on, it was found out that she was a BRCA1 mutation carrier. So once this had happened, she was offered prophylactic bilateral mastectomy with reconstruction. But however, she opted for breast conservation surgery. We went ahead with ultrasound guided wire localization with sentinel lymph node biopsy. And also since it was a tiny lesion, always any small lesion which we do, if it is visible on ultrasound, we always do the specimen mammography just to confirm that the lesion is out. So this is specimen mammography, and the final histopathology was a 6 millimeter tumor in greatest dimension with no LVI, and 3 sentinel lymph nodes were examined that showed only reactive changes, no evidence of metastasis. So she underwent RT and the subsequent chemotherapy, and right now she's on follow-ups. And next time when she's coming, we'll be doing a high-risk screening for her. So in known BRCA1 as well as BRCA2 patients, we have found out that the lifetime breast cancer risk, especially for BRCA1 and 2, it's around 60%, whereas for the general population, it's about 13%. What about the contralateral breast risk? That is up to 20 years. So in BRCA1, it is almost 30 to 40%. So almost 30 to 40% of the ladies who have got BRCA1 mutation will end up developing malignancy in the contralateral breast. And about 25% of the BRCA2 patients will develop in the contralateral breast as compared to 8% of the general population. And also we have, while taking the history, it's not just breast and ovary. We also have to ask history of any male breast cancer, or if there are any pancreatic or prostate cancers also that are associated with the BRCA mutations. And Fanconi's anemia as well as childhood AML history is also equally important. So I'll just show a companion case. This was a 35-year-old self-detected left breast lumpiness in the axillary region. But she was very confidently, she told her aunt had CA breast, so and was young. It was young cancer, so tested. She was tested to be BRCA2 positive. Her father had CA lung, and he also turned out to be positive for BRCA2. So since she was describing lumpiness in the axillary region, we proceeded with diagnostic mammography. So what are we seeing? So these are the images I actually obtained on full field digital mammography. You can actually make out the difference in the images. So her main concern was the lump in the axillary region. So whenever we report anything, we usually see put all the reports under three categories. The first one is what the patient describes. The second is what the clinician describes. And third is what we see on imaging that is not felt or not palpable. So she first described about the left axillary swelling. That was the reason for which she came. So this is a heterogeneously dense breast composition. Right breast was unremarkable. And this was the left axillary region concern that she was saying. So this corresponded to axillary fat pad. Now, what else are we seeing? We just saw a subtle mass in the left breast that is best seen on CC tomosynthesis. On MLO view, it was not seen very clearly. But on CC tomo, I'll just go to the next step. Yeah, this is the CC tomosynthesis sequence. We are able to see the mass quite clearly. But what we see is it seems to be a mass. It has actually got bilobe margins also and fairly circumscribed. So, but any mass seen on mammography has to be correlated with ultrasound. We went ahead and did an ultrasound, and this is what we saw. Why the image is not coming? Oh, so on ultrasound showed a hypoechoic mass with irregular margins with normal axillary lymph nodes. And then we went ahead with contrast enhanced mammography. And this actually before biopsying the mass, we had to make sure that it's a unifocal mass. So we went ahead with a contrast enhanced mammography, and this is what we saw. So it is actually a minimal background parenchymal enhancement. So this background parenchymal enhancement is very important in differentiating the lesion. So especially it's almost similar to that of what we see in MRI breast. It ranges from mild, minimal, mild, moderate, as well as marked. So in case of minimal as well as mild, the chance of missing out a lesion are very less. But in case of moderate as well as marked, there are again the chance of masking is possible. So in this case, even though it was a fairly dense breast, heterogeneously dense breast, there is only minimal background parenchymal enhancement. Right breast is normal. Left breast showed a unifocal mass. It was high conspicuous and with a heterogeneous pattern of enhancement and washout. And this is how the mass was looking on ultrasound. So what we saw was, you can see this actually heterogeneous pattern. And similar to the previous lecture, you can see that the mass, it's actually got a heterogeneous pattern with central necrosis. So this is what we had seen. We did a core biopsy and that showed invasive breast carcinoma grade 2. It was luminal B and desmoplastic stroma was seen. Her lymph nodes were normal. So since we already had got the CM, again the patient was, the risk of the surgery was described. Then she was BRCA2 study was sent for, but she opted for BCS. So while we waited for the surgery, that is within 2 weeks itself, the mass had significantly grown and it had become palpable. So we did wide local excision after marking along with sentinel lymph node biopsy. So one sentinel lymph node was found out to be positive, so we proceeded to axillary clearance, and the final HP was invasive mammary carcinoma grade 2 with associated DCIS, and 1 of 8 lymph nodes were positive. So for BRCA2 mutation positive patients, there is a high-risk screening protocol. And we have to remember that for any mass that we are seeing in a BRCA patient, there is no BIRATS3 on screening. So if you are seeing some mass newly in a patient or in the patient who is on screening, either it has to be benign or it has to be biopsied and proven to be benign. Breast conservative surgery can be performed in selected cases, but the main question is how long to continue screening. So generally it is told that the high-risk screening has to continue till the age of 70 years. But usually it is seen that after they finish about almost 8 or 9 cycles of screening, they really get fed up and proceed with prophylactic mastectomy. there is some role of chemo prevention that is coming up now. So ultimately, it is the imaging that helps to pick up the non-palpable lesions. So and what is the role of digital breast tomosynthesis as screening in high-risk patients? It's very useful, especially in the patients with dense breasts. There is increased cancer detection rate with DBT. It's like almost 4.1 as compared to 1.9 with the normal without DBT per 1,000 women screened. With the recall, what is most important is the recall rates are lower or comparable to those of digital mammography, and there is an increased cancer detection rate of almost 30 to 40%. So DBT helps us to catch the lesions that are definitely cancerous as compared to the 2D mammography. CEM has got a high negative predictive value in evaluation of breast lesions, and it can significantly reduce the number of screening recalls for benign breast conditions. CM also has significantly lower average granular dose than mammography protocols performed with tomosynthesis. And an initial study has shown that for the high-risk patients, when we perform CM alone, it has got lesser radiation dose as compared to DBT and MRI or DBT along with MRI for high-risk screening. So studies are still being done. So there are certain conditions like the patients with there are certain conditions where we have to go in for MRI, like the patient with the small breasted women or the means where we cannot adequately get the mammography compression. So these are the ladies who will definitely benefit with MRI. But for a woman who's got more of a fatty tissue and which can be positioned nicely in mammography, we are able to include everything. So definitely CM has got a role. Coming to case 2, we had a 61-year-old lady who presented with right bloody pathological nipple discharge in Jan 2024. We proceeded with the diagnostic mammography. Again, the CR images. So we were able to see scattered fibroglandular densities. The right breast, we could see a tubular structure in the retroareolar region, but she was having left axillary enlarged lymph nodes. So what we told her, okay, in that case, we did an ultrasound. So one single dilated duct was seen with some intraductal components. Left axillary lymph node was enlarged. We told her, okay, we can. There are chances that definitely the right breast she needs a biopsy, or it can be excision also. But we have to rule out occult primary in the left breast. So we suggested an MRI breast for her before proceeding with biopsy. So unfortunately, she was lost for follow-up due to personal reasons. Later on, she presented in August 2024 with lumpiness in the right retroareolar region, and she told the pathological nipple discharge continued. So now we'll be just seeing the difference. It's the same breast. So now it is being done with this, digital images. So some changes are more obvious now. We are able to see that she has got this dilated duct is more prominent. Plus, probably there is a subtle asymmetry that is developing over here. The lymph nodes are looking more prominent. So also the right nipple is retracted. That is better seen on tomosynthesis sequences. And this is the developing asymmetry. So we proceeded with, we told her, okay, we have to get some form of contrast. She agreed for the contrast enhanced mammography. And this was the ultrasound images. Again, hard lump. These are the CM images. And what we got was, there was an enhancing duct, this enhancing component that is seen in the right retroareolar region. She also had multiple enlarged lymph nodes, but the left breast was normal. So we proceeded with core biopsy of the right breast as well as from the left axillary lymph node. And the right was fairly surprised because we were expecting some papillary lesion, but in the right breast, we actually got invasive mammary carcinoma grade 2. It was luminal A. But the left axillary lymph nodes showed non-caseating granulomatous inflammation. So this lady also opted for right breast wide local excision with central lymph node biopsy. And that was subsequently confirmed on with clear margins on histopathological examination. It was a T1N0 lesion. So in this way, based on the clinical examination, on the clinical findings, the imaging, we are able to do a proper workup for the patient before she went in for the surgery. So using multiple imaging modalities, and definitely CEM has got a role. It's really, once you start using it, it's really, really good. Another case, this was a 32-year-old female. This is a slightly different case and more challenging. This was a 32-year-old female with recent onset right breast lump. She was currently nursing an 18-month-old child. She also gave a history of her mother having CA breast at the age of 37 years. We did a mammography for her. So based on this mammography images, we are not able to find out any lesions. So always we have to be careful. Like what the patient says is also equally important. There was heterogeneously dense breast with no discrete masses or calcifications, but her lesion was located in the right breast at 1 o'clock position, about 7 centimeters from the nipple. So there was a palpable irregular mass of 1.9 centimeter size. An echogenic rind was noted, and there was intralesional vascularity with no specific posterior features. And she also had a lymph node that showed a focal cortical thickness of 0.5 centimeters. So we went ahead with the core biopsy of the right breast as well as right axillary lymph node FNAC. So the diagnosis was invasive mammary carcinoma grade 1, again luminal A, and the lymph node showed lymphoid cells with no metastasis. She went ahead with the breast conservation surgery. The central lymph node was positive, so proceeded with axillary clearance. Adjuvant chemotherapy as well as RT was given, and she was on tamoxifen and ovarian suppression. And she presented for surveillance after 1 year. So now, this is the image that we have got. The left breast is normal, right breast is showing post-therapy changes. So I gave the report, okay, again follow up in 1 year. Now, 1 week after I did this study, I got a call saying, please evaluate. She has got an AVID lesion in the right breast. So please go back and evaluate. So she came. So what we did was I just had a look at the PET images. Okay, there was some bright spot. Had a relook at the mammography images. We did an ultrasound also, could not find anything. So we just called it off as inflammatory change. Now the question came, why should this patient have PET CT? So then I learned that she was actually planned for a bilateral salpingectomy, and she was describing some abdominal pain. They did ultrasound abdomen and pelvis. They found out a liver mass. And PET CT with FAPA, that is fibroblast activating protein inhibitor, is very, very specific. So that picked up a lesion in the breast. That's why she was referred. So now, so this was the reason why she got a PET CT. So then I had a look at the PET images also. So sometimes we go out of our breast way also to see what is happening, because being luminal A, the chances of her presenting with isolated liver metastasis was very, very unlikely. I had a look at the images. Definitely, okay, she was having a lesion in the right lobe of liver. So some more digging we did. So what did we find? Then actually I took the PET images and I had done a delayed scan also for her. But that lesion was showing enhancement. So the PET CT actually had mentioned that she has got a lesion, and she was actually being planned for biopsy from this lesion also to rule out metastasis. So then I told, okay, just hold. We'll just go through the images. So we just kept on digging. So PET delayed was showing filling up of the lesion. Then what I did was I picked up her ultrasound images pre-treatment, and this was the lesion. It was sitting there. The same lesion was sitting there. So even before treatment, she was having it. This was in July 2023 when she had presented initially. And then it was also seen in the thoracic CT chest images that were obtained. Then we spoke to the other colleagues also. We went ahead with an MRI breast, and this actually turned out to be a cavernous hemangioma. So always it helps. We have to look for the previous imaging of any modality for comparison. So as far as possible, please don't just go by the reports. If the images are available, the images don't lie. So just go through the images, and that is what is very, very essential for comparison. Coming to the last case, this was a 42-year-old lady who presented with right breast palpable lumpiness. So what we saw was there was definitely lumpiness, and she was having some calcifications also. And this was a lumpiness noted at 10 o'clock position, about 1 centimeters from the nipple. We went ahead with a core biopsy, and that showed sclerosing adenosis. And calcifications were demonstrated in the specimen. And she was put on a short-term follow-up with suggestion for contrast study in future. She came back for contrast study in July 2024. She told, since MRI appointments usually take at least 3 or 4 days, she opted for a contrast enhanced mammography. And in the right breast, corresponding to the palpable lump, there is a non-mass enhancement in segmental distribution. And we also found out that she was having an enhancing mass on the left side. And when we went ahead and did a second look ultrasound and we had a look at tomosynthesis, we could not localize the lesion in the left breast at all. So we went ahead again with the right breast core biopsy that showed from a different region, and that showed sclerosing adenosis. And for the left, since we didn't have the we don't have the capability of MR guided biopsy in our state, we just tried out the contrast enhanced biopsy. So again, we gave contrast, the breast was compressed, and we did a biopsy, and it turned out to be benign breast tissue with prominent vessels. So these are one of the few cases that have been done in India. So we also placed a clip in situ, and again, when she came back for a short-term follow-up, I was not able to find out any lesion in the region of the clip. So we have told her to come for a follow-up after 6 months. So just to show that we can even do contrast enhanced biopsy where the MRI biopsy capability is not available. So thanks for patient listening.
Over to you, Dr. Prekshi.
Yeah. So thank you, Dr. Janki. Ma'am, it was a wonderful talk. We have been fortunate enough today to be having all the stalwarts of breast radiology with joining our webinar. So yes, we have a plethora of investigations today, so which can ameliorate all the confusion related to the various cases, and definitely a discussion with the radiologist makes many confusion clear. I also thank to all the faculty members for joining here today, Dr. Jyoti, Dr. Madhvi, Dr. Richa, Dr. Rishu. So I would also like to thank the audience without whom this event of webinar will not be possible. Also, I would like to thank Mice Ideas team for conducting this session so very well. And last but not the least, I would like to thank all the seniors and the colleagues of FSIDC series. We'll soon be, again, we'll be there with a different and an interesting topic. So stay tuned. Good night till then. Goodbye. And thank you for joining, everybody. Thank you.
Thank you, Dr. Janki. Thank you. Thank you, everybody.